So let's move on the lymphoreticular malignancies. The malignancies of the blood. Some of the questions are coming from there. So let's go on a little bit slow for this. Topic is not much very big, but what are the important points? Leukemia is a group of neoplastic disorder of WBCs. It is WBC, white blood count, leukemia. The cells replace bone marrow. The cells replace bone marrow and may spill over into the blood and infiltrate other organs. Leukemias can be divided into myeloid and lymphoid. These are called myeloid and lymphoid. So, acute, or it can be acute, also called as blast or chronic. So you get acute lymphatic, acute lymphoblastic. So acute lymphoblastic, chronic myeloid. So myeloid lymphoid. Myeloid means you just see this is M and this is lymphoid. Leukocyte WBC has got the various cells where you have seen 5 different cells: neutrophil, phils, basophils, eosinophils, lymphocytes. So lymphocytes, lymphatic. Myeloid is group of neoplastic, these are hemopoietic precursor cells of bone marrow. And chronic is, this is myeloid. Group of characterized by uncontrolled proliferation. What is the difference between acute hemopoietic precursor cells of bone marrow? This is granulocytes. Specifically, neutrophil, basophil, eosinophil, these are granulocytes, and plasma cell mass, these are other are lymphoid cells. So in that again you get malignant transformation of lymphoblast, monoclonal expansion of lymphocytes. So it is CLL, chronic lymphocytic leukemia. Acute lymphocytic leukemia, ALL, lymphoid. This is related with lymphocyte, this is related with the granulocytes. Again, benign and chronic. So clinical presentation of leukemia is presentation depend on whether the condition is acute or chronic. Chronic is often asymptomatic but may have acute blastic phase or crisis. There can be. So most of the time they have got malaise, weakness, fever, polyarthritis, joint pain, weakness, malaise. Bone marrow failure causes pancytopenia. Anemia is there, infection is there, oral ulceration is there, gingival growth, bleeding disorders is there. Leukemic infiltration, bone pain, central nervous system, cranial nerves, hepatomegaly. What is pathology of leukemia? A clone of malignant cells may arise at any stage of maturation in either lymphoid, myeloid, or pluripotent stage. Etiology is thought to be genetic. In twin studies, Down syndromes, Philadelphia chromosome is seen. There can be viruses, radiation exposure, chemicals, alkylating chemotherapy, drugs. How you diagnose leukemia? Characterized by cells in the blood and bone marrow. Acute lymphocytic leukemia characterized by homologous infiltrate 30% of the lymphoblast. You see, lymphoblasts means lymphoblast, acute leukemia. No granules, indistinct nucleus. Myeloid leukemia, bone marrow show blast cells of myeloid origin. Multiple large nucleoli. Delicate chromatin, blue chromatin, or rods. AML or AUER or rods. Diagnostic of AML. This is the question. Acute myeloid leukemia, AML. And acute lymphoblastic, you get lymphoblast. In myeloid, you get multiple delicate chromatin. Blue cytoplasm, gray-blue cytoplasm. So this is granulocytes. Therefore, acute myeloid leukemia. Myeloid group, lymphoblastic group. Chronic lymphocytic leukemia, 30% of the lymphocytes, again lymphocyte has to be there, mature with 55% atypical blast form, nuclei are round, cytoplasm scanty, chromatin is compact, nuclei are inconspicuous. Chronic lymphoblastic, if you give chronic myeloid, bone marrow is hypercellular, expansion of myeloid cell lines, neutrophil, eosinophil, basophils, progenitor cells. Specific forms of leukemia, acute lymphocytic leukemia, ALL, childhood, ALL, child, lymphoblast, lymphocytes, B cell, T cell, bone pains, fever, neutropenia. Now myelogenous means age is more, AML, 65 years supposed to be the median age. Men common, complication of chemotherapy, hepatosplenomegaly. Now CLL, lymphocytic chronic, lymphadenopathy, lymph nodes, beta cell, chronic myelogenous leukemia, acute lymphocytic, acute myelogenous, myeloid lympho, acute, chronic, acute, chronic. So there will be 1, 2, 3, 4, AML, CML, ALL, CLL. So ALL was child, AML was adult men, CLL chronic lymphocytic leukemia, again men, CML 40 to 50 male. Males are commonly affected. Just try to remember, males are commonly affected. So this was about leukemia. Okay, this is lymphoreticular malignancy. Now what is lymphoma? This is reticuloendothelial cell system. This has got Hodgkin, non-Hodgkin, HL, non-HL. Lymphoreticular, basically just try to bring in mind, it is with the, not with the cells, it is with the location. It may be classified Hodgkin, non-Hodgkin, Hodgkin dependent affects young. H again for young. This has got good. This is old, bad prognosis. Males, again the Hodgkin lymphoma has got lymph node enlargement. Think of lymph nodes. Lymphoma, lymph node. Leukemia, acute myeloid leukemia, lymphoid leukemia is cells. Fever, weight loss, superior vena cava obstruction because of increased lymph nodes. Pathology is RSL, Reed Sternberg cell. There it was our rods were seen in AML. And here you get RS cells, Reed Sternberg cells, rubbery nodes. Bones can be reclassification of Hodgkin. This is Hodgkin. Now if their lymphocytes predominant, nodular grazing, mixed, these are again. Staging is Ann Arbor, this is different, Ann Arbor classification. Absence of systemic symptoms, presence of above symptoms, depending upon whether this is called as B symptoms, confined to one lymph node, more than one lymph node side, and confined to diaphragm. So this is one part, lymph node side, more than one lymphocyte other part, and spread beyond lymphatic, extra lymphatic. So how is this? Symptoms: fever, weight loss, night sweats. Weight loss, fever, night sweats. Fever, weight loss, night sweats, and absent. Then one group lymph node site, more than one will again above, below diaphragm, extra lymph node mets. Node biopsy has to be done. Chest X-ray, mediastinal lymph node. All these staging laparotomy for knowing where is it. Radiotherapy, good prognosis. Hodgkin's, 1-2 combination, 1 RT, 2 to 4 CT. Lymphocyte is present, it means it is a good prognosis. NHL, tumor originating from lymphoid tissue, mainly of the lymph nodes. They are progressive clonal expansion of B cells or T cells. They are why 85% is B cells. More than 50 years age group can be seen children. Classification based on morphology, low medium. Discuss about same. Chemoradiotherapy. Bone marrow transplant may be considered for relapses. So that was leukemia, lymphoma, multiple myeloma. This is the third. This is with the plasma cell. So different types of cells we have seen. WBC count, WBC white blood cells are of different types. If you see, these are the granulocytes, right in the first. I'm scrolling on the PC to see what are the different types of cells which you have read in the beginning. So you get leukocytes have got phils, neutrophil, basophil, eosinophil. Then lymphocyte and monocytes. The monocyte they basically form. Hemopoietic they have got stem cells. They have got two different categories, myeloid and lymphoid. Myeloid, RBC, platelet, and among WBC, granulocytes. These are basophil, eosinophil, neutrophil. Then you have got monocytes. And myeloid dendritic cells. Then lymphocytes have got B and T. Among that there is one natural killer cells also. Then plasmoid dendritic, and myeloid dendritic and monocyte, they called APC, antigen presenting cells. So plasmoid dendritic monocytes, plasma cells resulting in gradual displacement of bone marrow with the cancer cells. It causes pancytopenia, bone symptoms. Multiple myeloma is malignant production of monoclonal plasma cells with production of individual paraprotein common in 60 to 70 age group. Plasma cells cause pancytopenia, anemia, bleeding, lytic. Bones are lytic. Bone pains, hypercalcemia, spinal cord compression. Produce antibodies are overproduction, renal hyperviscosity, amyloidosis. Impaired humoral immunity, susceptible to infection in encapsulated organisms. Asymptomatic patient identified with the screening, diagnostic of total proteins, albumin and globin has to be given. What is pathology of multiple myeloma? Etiology is thought of combination of genetic factor, environmental factor, exposure to chemicals, radiation. WBC normal evidence of pancytopenia. ESR is always high. Urea electrolyte renal failure. Calcium is often raised. Uric acid is raised. You get Ben Jones proteins in myeloma, multiple myeloma, BJ proteins. This is the specific. Paraprotein is there, beta 2 microglobulin and CRP is also erased. Skeletal osteoporosis is there, crush fractures, osteolytic lesions, paper pot skull. Classification of myeloma, then again based on monoclonal products, it is on staging of multiple myeloma 1, 2, 3, more than 10 HB, calcium less. If hemoglobin less, it is 3. Staging is, then creatinine is raised more or not, that is another thing. There are 3 stages includes renal function. A is normal creatinine, B is elevated creatinine. Mean survival for stage 1. Diagnostic myeloma, monoclonal band on the plasma, benzoin protein in urine, plasma cells on bone biopsy. Osteolytic lesions they cannot diagnose. High dose radiotherapy is to be given. Hydration bisphosphonates for hypercalcemia is highly radiosensitive. This was about